Usual, I want to thank everybody who is joining to today's seminar. As you know, today the seminar it's about chronic subdural hematoma. We have the pleasure to have connected as an expert and speakers Professor Clarenson, Dr. Sotar, and Nader Surur from La Pitié Salpêtrière in Paris, as well as we have the pleasure to count in today's webinar with Dr. David Fiorella from New York. I will explain briefly the agenda and how we are going to deal. Firstly, Dr. Sota will introduce a little bit about the study that we are conducting, or he is going to help us to conduct. Then Professor Clarenson will speak about his experience with particles for the management of these patients. And then Dr. Fiorella will continue sharing his experience with liquid embolic for the management of these patients. As in other occasions, I am inviting you all to go through the tool question and answer, to write all the questions that you have after each of or during the presentation. Then once each of the speaker finish his talk, I will start to read the questions, and the experts will be providing the answer to all those questions. So when I have done this introduction, I want to give the word to Dr. Sota, who will start with the presentation. Thank you, everybody.
Good afternoon, everybody, or good morning, I don't know. So Dr. Shota will start the presentation. He will talk about the pathophysiology of the chronic subdural hematoma, and he will talk about the rationale of the embolization of chronic subdural hematoma. So I will launch the PowerPoint.
Thank you, Frederic. So as you've said, I'm a practitioner in the intervention neuroradiology department of the Pitié Salpêtrière Hospital in Paris, and I'm going to talk about the physiopathology of chronic subdural hematomas and the rationale of middle meningeal artery embolization in this condition. As you all know, acute non-traumatic subdural hematoma is extremely rare and is mostly related to microscopic vascular conditions such as aneurysms, brain AVMs. Here's an example we've published a few years ago of a patient that's presented with a non-traumatic acute right convexity and valcoreal subdural hematoma, which was compressive and surgically evacuated. A few hours later, the patient presented with renewed bleeding in the subarachnoid space. So, and an angiogram was performed that demonstrated a left paracentral brain AVM that was related to distal flow related aneurysm, which explained a posteriori the acute subdural bleeding and the acute subarachnoid hemorrhage. So this is non-traumatic acute subdural hematoma. It's extremely rare. By contrast, chronic subdural hematoma is extremely frequent. As you can see on this slide, chronic subdural hematomas have a variety of radiological presentations. They can be either hypodense, isodense, hyperdense, it can be separated, they can be present septations or can be layered. It's extremely varied. All these are chronic subdural hematomas. Everybody recognizes the chronic subdural hematoma, even though there is no formal definition of the pathology, either in terms of radiological presentation or duration of installation of the hemorrhage in relation to the minor head trauma that in most patients precedes the constitution of chronic subdural hematomas. Chronic subdural hematomas are much more frequent than acute subdural hematomas. Figures vary depending on studies, between 2 and 20 per 100,000 individuals per year. It's probably closer to 10 to 20 than 2 per 100,000. In the 80s, a study was conducted on the Iwajima Island in Japan that found that 13 or 14 per 100,000 1,000 individuals presented yearly with subdural hematoma. The striking finding of the study is that chronic subdural hematomas tended to be 20 times more frequent in patients that were older than 65 years in age. What this shows is that chronic subdural hematomas is predominantly a pathology of the elderly population because of brain atrophy, because of the role of minor head trauma in the physiopathology, and because of increasing role of antiplatelet and anticoagulant therapy in this aging population. It's anticipated that chronic subdural hematomas, which are already quite frequent, are going to increase in incidence in the coming decades. Another striking finding from the demographic literature is that not only there's an increase in chronic subdural hematoma incidence, but there's also a shift in the hematoma age distribution. Here you have an age distribution diagram for chronic subdural hematomas in different departments in the 70s, in the 90s, and in the 2010 decade. What this shows is that the mean age of patients that were admitted with chronic subdural hematomas has increased by several decades through the last years. Today, patients we treat with subdural hematoma have a mean age of 75 years, which is more than 5 years older than the thrombectomy population we are imagining. So these are very old patients, which explains in part the morbidity and the mortality of the pathology. Patients we admit with chronic subdural hematoma are advanced in age and they have comorbidities, and chronic subdural hematoma, contrary to common wisdom, is not a benign disease. It has a mortality rate of 4%, around 4%. This has been demonstrated in meta-analysis of randomized trials and observational studies. It has a morbidity of around 10%. It has a cure rate of 80 to 85%, which means that there's a recurrence rate of around 10% for this pathology. And it's thought that chronic subdural hematomas is some kind of a sentinel event which predicts future mortality akin to hip fracture, for instance, in this age population. There is, for chronic subdural hematomas that are symptomatic, there is a simple and efficient treatment, which is surgical evacuation. In most institutions, it's done either through a twist drill or a Burhel craniostomy, which allows chronic subdural hematoma evacuation and mass effect reduction. There is a clear beneficial effect of draining the hematoma for 24 to 48 hours after the surgery, which has been demonstrated in retrospective studies and in a randomized controlled trial that was published in Lancet in 2009. Here you see the lower, above the relative risk for recurrence after drainage, which is lower than 1 in meta-analysis of randomized trials and non-randomized studies. In the past few years, a new treatment is emerging for chronic subdural hematomas. It's embolization of the middle meningeal artery. It's a treatment that has been proposed using different embolic agents, including PVA particles, coils, either proximal or distal, cyanoacrylic glue, or even ethylene vinyl alcohol copolymers like onyx, depending on authors, anatomical presentation, and local preferences. So where does this proposition to treat chronic subdural hematomas by middle meningeal artery embolization fit in our understanding of chronic subdural hematoma pathophysiology? Here you have a diagram that shows on the left a normal patient and on the right a patient that has a minor head trauma. You can see in the patient with a minor head trauma that there is a tear following the trauma in the border cells layer, which is this cell layer separating the meningeal dura sheath from the arachnoid barrier. This minor tear can result either in an acute traumatic subdural hematoma or a hygroma, which is a liquid collection in this border cellular layers. Here you have an example in our practice where a patient presents at the emergency department after a minor head trauma under antiplatelet therapy. On the left, you have a CT scan at the level of convexity, on the right at the level of the basal ganglia. And what you can see is that this patient between admission day and a few weeks later has transformed his acute traumatic subdural hematoma into a chronic subdural hematoma with a lower density, and most importantly, a subdural hematoma that has autonomized. It has increased in size from the admission day to the control CT scan, and the patient has become symptomatic with a mass effect, as can be illustrated with the midline shifts. Acute subdural hematomas are not the only initial lesion that can lead to chronic subdural hematomas. Post-traumatic hygromas can also evolve into chronic subdural hematomas based on the same physiopathological mechanism. That is a minor head trauma that leads to a tear in the border cell layer. On the left, you have a CT scan of a patient presenting at the emergency department after a minor head trauma that was interpreted as normal, which in fact presents with a minor bilateral liquid hygroma, which is post-traumatic, which a few weeks later led to the development of a bilateral chronic subdural hematoma, which this time is compressive, as you can see with a marked mass effect on both hemispheres. So what can explain such an evolution from an acute subdural hematoma or a post-traumatic hygroma into a chronic subdural hematoma? Actually, it's not one phenomenon, it's a conjunction of the phenomena that concur to the development and the evolution, the autonomous evolution of chronic subdural hematomas. First line of phenomena that occur in subdural hematoma is a recruitment of inflammatory cells. So here you can see the secretion by inflammatory cell of interleukins that colonize the liquid component of the subdural hematoma. A second mechanism is the development of subdural hematoma membranes by membrane proliferation. The outer membrane of the chronic subdural hematoma is usually thick, while the inner membrane is less prominent. There's a phenomena of cell proliferation. These cells originate from the border cell layer, and there's also a proliferation of extracellular matrix. Third phenomena that concurs to chronic subdural hematoma is fibrinolysis. The clot of the chronic subdural hematoma never clots actually, it stays liquid, which explains partly the autonomous evolution and also explains the radiological representation of chronic subdural hematoma, which can be separated, for instance, with erythrocytes that are drawn downwards in a patient which is laying on his back. And last mechanism, which starts to explain how middle meningeal artery embolization can contribute to chronic subdural hematoma treatment. The last phenomenon in chronic subdural hematoma pathophysiology is angiogenesis, which is promoted both by membrane proliferation and vascular recruitment and inflammatory phenomena, which lead to development of highly leaky capillaries in the external and internal membranes of the chronic subdural hematoma. What's most interesting is that these capillaries are fed by arterioles that cross the dura and are themselves fed by the middle meningeal artery, which is the main artery of the convexity, as you know. These vessels are termed in the literature the sinusoid neovessels, and they have the particularity of having leaky gap junctions, so the both erythrocytes and plasma leaks from these sinusoid neovessels from the outer membrane of the chronic subdural hematomas, mainly into the cavity of the chronic subdural hematoma. we have a few radiological observations that also tend to show implication of the middle meningeal artery in the pathophysiology of chronic subdural hematoma. And a very interesting observation by the team of Takizawa was published in 2016, where they compared the caliber of the middle meningeal artery on the time of flight MRI angiograms, homolateral and ipsilateral to chronic subdural hematoma. As is shown in this example, the middle meningeal is dilated on the side of the chronic subdural hematoma, which is an indirect observation that tends to demonstrate the implication of this artery in the pathophysiology of this disease. Here you have a graph showing the comparison of the caliber of middle meningeal arteries, which were compared to non-hematoma site in the same patients, showing an increased mean caliber of the middle meningeal artery ipsilateral to chronic subdural hematomas. Middle meningeal arteries were also compared to controls and were demonstrated to be larger in calibers, again against controls. We've conducted the same studies based on angio-CT scans and measuring this time the caliber of the middle meningeal artery below the skull base in order to limit the risk of measurement bias, and we found the same results actually, an increased caliber of the middle meningeal artery on the side of the chronic subdural hematoma in comparison to matched controls, as well as in comparison to the contralateral side of unilateral chronic subdural hematoma. So an indirect observation of the possible implication of the middle meningeal artery in the pathophysiology of the chronic subdural hematomas. Another interesting finding is the angiographic demonstration of the capillary blush in patients having chronic subdural hematomas. Middle meningeal arteries tend to be increased in caliber, both on CT scans, MRI, and angiography, and also on angiographies demonstrate what has been called cotton wool aspect of the dura, which is supposed to be the angiographic demonstration of the presence of these so-called sinusoid nerve vessels in the outer membrane of the hematomas. Another interesting study was made in patients having undergone middle meningeal artery embolizations for chronic subdural hematomas and CBCT scans in the same context, and that show the enhancement of either the outer inner membrane of chronic subdural hematomas. A study has been published by another team in New York a few weeks ago, demonstrated the same effect with a quasi-systematic enhancement on CBCT scans post-embolization of the outer membrane, the inner membrane, the septa, and the subdural hematoma cavity in patients with chronic subdural hematomas. Based on these pathophysiological hypothesis and the possible implication of the middle meningeal artery in the pathophysiology of chronic subdural hematomas, a team by Ban et al. Has published a very interesting study in radiology in 2015-17, which most of you have heard of and even read. It's a monocentric prospective non-randomized study comparing a population of patients undergoing embolization to a historic group. Patients were included if they were older than 20 years and excluded if they had focal chronic subdural hematomas or chronic subdural hematomas lower than 10 millimeters in diameter and thickness or without mass effect. Patients had to have no underlying medical condition and have a life expectancy of more than 6 months, so they were excluded in case of diminished life expectancy. Their clinical protocol was to propose a curative middle meningeal embolization for patients with chronic SDH, which were asymptomatic, and for patients that were symptomatic to propose surgery following embolization. Here's the main result of their study. The primary endpoint was a composite, and it was termed treatment failure. It included incomplete chronic subdural hematoma resolution on the CT scan at 6 months, or surgical rescue for unoperated patients, or the need for recurrent surgery in patients that had undergone both surgery and embolization. And the main result is that embolization, in comparison to the historic control group, reduced very significantly the risk of treatment failure in patients managed with chronic subdural hematoma. The effect of middle meningeal artery persisted in the study, whatever the subgroup that was tested, either patient operated or not, for patients with large compared to small subdural hematomas with symptomatic versus asymptomatic, or unilateral versus bilateral hematomas. So the effect of middle meningeal artery seemed to be quite large scale and massive in this population. We've also conducted a local study, which we've submitted recently in GNIS. Our local protocol is to propose embolization for patients which have undergone surgery of a subdural hematoma by craniostomy, either for a chronic subdural hematoma recurrence or after a first surgery in case of an independent recurrence risk factor, including antiplatelet therapy or anticoagulant therapy or coagulation disorder or hepatopathy or chronic alcoholism. Here's the flow chart that summarizes our study. It's again a study against a historic control group. The historic control group was composed of patients operated between 2016 and 2018. 310 patients were operated for chronic subdural hematomas during this period. 174 were operated for 210 chronic subdural hematomas, which corresponded to the pre-specified inclusion criteria. This control group was compared to a group of 89 patients that were operated and embolized for 104 chronic subdural hematomas. Here's the main result of our study. On the top of the slide, you can see the Kaplan-Meier recurrence-free survival rate in the patients with an embolization as compared to the control group. The main result is that embolization, which was performed with particles in our case, significantly reduced the rate of recurrence, surgical recurrence in the study population, which was reduced from 40 to 4%. There persists a risk of recurrence in our population. Nevertheless, I remind you that this is a population of patients with high risk of recurrence as compared to the BANYAR study, which was performed on the general chronic subdural hematoma population. So, in summary of this first introduction about chronic subdural hematoma pathophysiology, this is a disease which is having an increased incidence because of increased age because of aging of the general population and increased use of antiplatelet, anticoagulant medication. There is an effective surgical treatment for symptomatic patients, but there is a risk of recurrence for such patients. There is a pathophysiological rationale to propose middle meningeal artery embolization in the context of chronic subdural hematomas. There are preliminary results that tend to show there is maybe a benefit for this procedure, but this needs to be demonstrated formally, of course, in a randomized controlled trial, which I'm sure is going to take place in the following years. So thank you, and I'll leave Frederic to speak about our local experience and the tips and tricks about embolization.
Thank you, Emad. So,
Frederic, there is two questions that maybe I can ask right after Dr. Sota presentation.
Yes.
Yeah, we have a question from the Musana Asfar, who is asking how you get the suspicion of relation between MMA and DSDH.
So this is what I've said earlier. There's a certain number of observations that tend to show that there may be a relation. First of all, there's an increased size of the middle meningeal artery. There's a radiological observation of the cotton wool aspect of middle meningeal artery angiogram. There's the histological observation of the presence of the sinusoid neovessels in the outer and inner membranes of chronic subdural hematomas, and the fact that these sinusoid neovessels are related to the middle meningeal artery, since this middle meningeal artery, MMA, is the main feeder of the dura mater of the convexity. So it's not a single observation that tends to show there's a relation. It's more of a streak of arguments. I don't know if this answered your question.
And I think the next questions probably will be answered through the presentations, because are related to if you embolize only one side or you embolize bilateral. So I think through the presentation of Professor Clarenson,
yeah. Maybe we'll discuss it afterward, maybe after the discussion on the embolization. So Dr. Chota told you about the rationale for the embolization of the chronic subdural hematoma, and I will talk to you about how I do it. How do we embolize this chronic subdural hematoma through the middle meningeal artery? So I will first speak about the access. We will see sometimes the access is very difficult because it's a very old patient. I will share with you some tips and tricks, and I will present you how we embolize in one institution this chronic subdural hematoma with microparticles, and Dr. David Fiorella will talk to you later on about embolization with EVOH of the chronic subdural hematoma. So, as Dr. Chota told you, in our experience, the mean age of the patient that we treat for chronic subdural hematoma is 74 years. And when we compare it to the patient treated for mechanical thrombectomy, the median age in the meta-analysis for this patient is 68. So we are treating for this chronic subdural hematoma old patient with who will have more tortuous vessels, who will have some ateroma, who will have such ugly aortic arch and bovine arch. So this is some example of CTA of the patient treated in our institution for chronic subdural hematoma. So you can see here this bovine arch with some huge loop at the origin of the common carotid artery on the left side. On the right side, here you have this type 3 aortic arch. So all this anatomic configuration could be very challenging for the access. So our recommendation in our institution is to systematically perform a supraortic trunk CTA before the chronic subdural hematoma embolization to depict a type 3 aortic arch, to depict some loop at the origin of the common carotid arteries, to depict sometimes a bovine arch, and also to see if there is some severe ateroma. And also, you have a surrogate marker of an MMA arising from the ophthalmic artery, which is the absence, the agenesis of the foramen spinosum. So if you have no foramen spinosum, you don't have to do the embolization because probably the middle meningeal artery will arise from the ophthalmic artery. Another technique which could be used for the embolization of the chronic subdural hematoma is the radial access. It could be very helpful in case of bovine arch, of course, in case of loop at the origin of the common carotid artery, in type 3 aortic arch for the catheterization of the right external carotid artery. And also, it helps to reduce the risk of grain puncture severe complication. And in our experience, so about 100 cerebral hematoma embolized, we had one severe complication, which was a groin puncture complication, a dissection of the femoral artery, which required a bypass, and eventually the patient died because it was a very old patient, and she died from the complication of the bed sore. So in using the radial access, you will reduce the complication of the access, especially for the groin puncture. So what we developed in the department is what we call a tailored access. So we always do CT angiography before doing the embolization of the chronic subdural hematoma, and we can determine on this CT angiography which is the best access. So if it's a bovine arch, for instance, we will use radial access. But sometimes, if you have to catheterize the left external carotid artery, the radial access may be more challenging, and the femoral access may be maybe easier. So the radial access in all cases may not be suitable. So we did a retrospective study in our institution. So EMAD just submitted to a JNIS recently, and we compared the first period of flow experience in which we treated all the patients via a femoral access, so more than 40 patients, and you can see that we had 10% of failure with the femoral access. And when we use this tailored strategy, so based on the CTA, either by radial access or by femoral access, depending on the anatomy of the aortic arch and the carotid trunk, we had only 1% of failure in catheterization. So this tailored access may help to reduce the rate of failure. So here an example of such tailored access. So this is an 82-year-old male with this right chronic subdural hematoma, which was evacuated surgically. And you have on the CTA this bad aortic arch, so a type 3 aortic arch with this loop, with this huge loop at the origin of the right common carotid artery. So if you listen to this to Pascal Jabot, you should go radial, and that's what we did. So with the radial access, it's very easy. So we navigated a supple 6 French guiding catheter over a 5 French Siemens catheter, and it's very easy to go in the right common carotid artery. From femoral access, probably it would have been much more difficult, and after, you just have to navigate a ProVec microcatheter, do the run, and embolize with microparticles or liquid embolic agent. But with this radial access, it's very easy. So radial access is very trendy nowadays. The embolization of chronic subdural hematoma become very trendy. So if you do both at the same time, you will be super trendy. So you have to think about this radial access for the embolization of chronic subdural hematoma. A few words about the tip and trick for the embolization of the middle meningeal artery for this chronic subdural hematoma. The two main risks are the anastomosis with the ophthalmic artery, which could lead, if there is a non-controlled migration of the embolic agent, to monocular blindness. And also, there is the petrosal branch, which arises at the origin of the middle meningeal artery. And if you have a non-controlled migration of the embolic agent in this petrosal branch, you have a risk of facial nerve palsy. So you have this drawing from the website of shapiro-neurongeo.org. And you can see here, this is the middle meningeal artery, the foramen spinosum. So here you have the anastomosis with the ophthalmic artery of the middle meningeal artery, and here the petrosal branch, which is at risk of facial nerve palsy if you have a migration of the embolic agent. Here a summary of the anastomosis between the external carotid artery and the ophthalmic artery. And when you embolize through the middle meningeal artery, you have to be aware of this anastomosis. Mainly the anastomosis between the middle meningeal artery and the lacrimal artery, and between the middle meningeal artery and the ophthalmic artery. So a couple of examples of this dangerous anastomosis. So here you have a right IC-ADSA in AP and lateral projection, and you can see here this hook, which is the origin of the middle meningeal artery arising from the ophthalmic artery. And on a later phase, you have these straight arteries, which are the branches of the middle meningeal artery. And you see this tube here of the middle meningeal artery arising from the ophthalmic artery, and you can see the course of the middle meningeal artery. So this configuration definitively is a no-go configuration. You cannot go, it's not safe to go through the ophthalmic artery to embolize the chronic subdural hematoma if you have this configuration. Another configuration is the meningo-ophthalmic artery. So in our experience, we have this such variation in 3% of the cases. So in this configuration, the ophthalmic artery will arise, will be fed only by the middle meningeal artery. So you can see it's the course of the ophthalmic artery, which arises from the middle meningeal artery. You can see it on AP projection. And this meningo-ophthalmic artery has a course which goes through the superior orbital fissure. So this is also a no-go configuration because it's too risky, because the ophthalmic artery, the middle meningeal artery is the only feeders of the ophthalmic artery. Another tricky configuration is this configuration. So here you have a selective catheterization of the middle meningeal artery. You do a run and you don't see any ophthalmic artery rising from the middle meningeal artery. Then when you push more distally your microcatheter and you do a wedge injection, you see that the ophthalmic artery is also fed by the middle meningeal artery. So you see it in lateral projection, in AP projection, and this configuration corresponds to this anatomic configuration where you have the ophthalmic artery, which is fed by the ICA, but also by the middle meningeal artery. So in this configuration, you could do the embolization, but you have to do it with precaution. What we recommend is to occlude the origin of this connection between the middle meningeal artery and the ophthalmic artery with coil, to be sure that you won't have any migration of the embolic agent towards the ophthalmic artery. Another anastomosis which could be dangerous is the meningolacrimal artery. So here you have an example. We find this configuration in 10% of the cases. So it's not so rare to have this meningolacrimal artery. So in AP projection, you see this connection between the middle meningeal artery and the lacrimal artery. And this is a go configuration, but with precaution. And what we recommend is to navigate in this meningolacrimal artery and to occlude it with coil. So you can see the coil here to be sure that you won't have any migration of this of the microparticle or the liquid embolic agent towards the ophthalmic artery. And as I told you, the other risk is to have reflux of the embolic agent at the proximal aspect of the middle meningeal artery and migration of the embolic agent towards the petrosal branch of the MMA, which is one of the supply of the seventh cranial nerve, and which could lead to facial cranial nerve palsy. So what about the embolization with microparticles? So what is the rationale to embolize with microparticles? So first, it's very simple. We are doing embolization with microparticles for many years for meningioma, for instance. It's very safe, it's very quick, and you have distal penetration of the particle which are injected with a free flow. What are the main drawbacks of the embolization with microparticles? So you require a large bore microcatheter to inject this microparticle. You have the risk with the dangerous anastomosis. And we all know that with microparticle, you only have temporary occlusion. So a few words about the literature on the embolization of middle meningeal artery. When you look at this systematic review of the literature, when you see which was the embolization material that was used for these cases, in almost all the series, it was microparticles. In a couple of series, it was NBCA, but it was a very low population series, but in most cases, it was PDA. So there is a huge experience in the literature using microparticles. And also, it's very safe. When you look at the result in terms of safety of the biggest series in the literature, so you have the series of Ban et al. That Emma told you about, 72 cases, embolization with PVA microparticles and no complication. More recent studies, a case series with almost 50 patients, 60 chronic subdural hematoma, also with PVA microparticles, no complication. And in our local series, we embolized more than 100 chronic subdural hematoma with a little bit bigger microparticles in about 90% of the cases, and we had no complication related to microparticles. So it's very safe. So you know how it works, the microparticle. So we are injecting the microparticle with it's a free flow injection with a microparticle which will occlude the distal vessel. So we will have distal occlusion with this microparticle. So we are embolizing for many years through the middle meningeal artery with microparticle, especially for meningioma. And it's not so. It could be dangerous if you don't respect some security rules. We published this paper a couple of years ago for the embolization of meningioma with microparticles, and the complication rate was not so low. It was 1.5%. So here an example of such complication. It was this meningioma, this parieto-occipital meningioma on the left side. You have the DSA in AP and lateral projection from the left external carotid artery. You can see the blush here. And here the operator navigated the microcatheter, and you see that maybe the microcatheter was wet because when you inject at the left face, you can see the reflux in the posterior meningeal artery. So the operator did a mistake and injected some microparticle in wedge, which is not recommended. And when the patient, after the embolization, the patient experienced the cellular syndrome and cortical blindness with all this infarct in the occipital lobe and in the cerebellum, which were related to migration of the microparticles through the anastomosis towards the posterior meningeal artery. So you have to be careful when you do this embolization. It's very simple, very safe, but you have to respect some basic rules to avoid such complications. The other drawbacks of the embolization with microparticles is that we know that there is a delayed recognition after embolization with microparticles. The pathomechanism is not well known. It could be extravasation, or maybe it could be neoangiogenesis, but we know that's not a definitive treatment. We have recognition, the delayed recognition. And Emad showed you this Kaplan-Meier curve. This is the evolution after embolization and in the control group. And you can see that in the embolization group, we have no recurrence within the first 45 days. So maybe this delayed recognition could explain the late recurrence of subdural hematoma that we depicted in the embolization group. And to conclude, we have also to keep in mind the branching pattern of the middle meningeal artery. In most cases, you have two branches, an anterior branch and a posterior branch, so it's called the frontal branch here and the parietal branch. Some authors, like Adashik, describe three branches: the bregmatic branch, the oblique branch, and the lambdoid branch. But in most cases, you have these two branches, one anterior branch and one posterior branch. And you have to know that the configuration could vary from one patient to another. So the three drawing here represent the more common pattern of branching of the middle meningeal artery of these two branches. So it represents about 90% of the anatomical configuration of the middle meningeal artery. And when you look at this drawing, you see that the proximal arising of the posterior branch is observed in about 2/3 of the cases. So in such cases, if you use a liquid embolic agent, you will have to catheterize first the anterior branch, then the posterior branch, because you cannot embolize from a proximal point with liquid embolic agent, because you have a risk of migration of the embolic agent towards the petrosal branch. So when you use a liquid embolic agent, such configuration, you will have to catheterize both branches. But with microparticle, you can inject from here with free flow injection, and it's less risky. So an example of this patient, it was a 73-year-old female who was alcoholic. She had this left chronic subdural hematoma, which was treated surgically. And here you can see the external carotid artery DSA in lateral projection. And here, so you have this branching pattern with a posterior branch which arises very low on the middle meningeal artery. So here, if you embolize with a liquid embolic agent, you have to go first in this branch, embolize, and after go with another microcatheter in this branch and embolize with glue. It's not recommended to embolize from here because you will have a risk of migration of the embolic agent in the petrosal branch. So we did this embolization with microparticle from the proximal aspect of the middle meningeal artery. You have still some flow in the anterior branch, and we finished with this coil. And you can also one of the difficulty of this embolization is that we are doing this embolization under local anesthesia, and usually the patients are moving a lot, so sometimes it could be difficult to inject either particles or liquid embolic agent in such patient moving a lot. Here you have the result at the end of the procedure. So we occluded the middle meningeal artery and we put in some coil to be sure that we had a good occlusion. And just a last slide about a risk of potential complication, which are meningo-meningeal fistula. So in such patients who are moving a lot, maybe during the catheterization of the middle meningeal artery, you can have perforation of the middle meningeal artery, which could lead to such meningo-meningeal fistula. you know that the meningeal vein are side by side with the meningeal artery, and so you can, if you have a tear in the wall of the middle meningeal artery, you could have such a meningo-meningeal fistula, which would be treated. It's not a serious disease. You can treat it very easily with coil or liquid embolic agent. So thank you for your attention, and I will move forward for the presentation of David Fiola on the embolization with EVOH of the chronic subdural hematoma.
Thanks a lot. Yeah, that's good. You guys can hear me?
No.
Good. I'll just share my screen here. You guys can see okay?
Yes.
Great. So I'll present our experience with liquid embolic agents for the embolization of chronic subdural hematomas. I've done a lot of this work again with Adam Arthur, and the two of us are collaborating on the upcoming STEM trial using SQUID for this application. As we've covered, the pathology of this is one of leaky membranes, where you have these membranes over the subdural space that are continuously bleeding and leaking into the subdural space, and that outstrips the ability of the brain to resorb that blood and those blood products. And so our idea is to get rid of these leaky membranes and to switch the balance so that the resorption rate of the hemorrhage outstrips the continuous recurrent bleeding rate. So we're trying to change the physiology from leaky membranes to membranes that will resorb the hematoma. So I started out by using PVA particles like everybody else did, and quickly decided to switch over to liquid embolic agents, and the only one that we have that's approved in the United States right now is Onyx. And so this is what I've been using, Onyx 18, to do these cases. And I've switched over for a couple of reasons that I'll demonstrate. So in terms of doing the procedure first, how do we do these? We use general anesthesia for some procedures, but more and more now we're doing these under conscious sedation. So initially we were doing general anesthesia because the injection of DMSO was somewhat uncomfortable for patients. But recently we switched over to doing many of these cases under just conscious sedation. It just depends on the patient's level of impairment and ability to hold still during the procedure. Again, we started out doing these cases from femoral access using a benchmark catheter and a 6 French access. We switched over almost entirely to doing these cases from radial access, and we're just putting in a 5 French sheet and using as our guide catheter a 5 French Simmons 2 glide cath. And so almost all of our cases now are radial access unless there's some reason for us to do these from a femoral access. The microcatheter that we're using for almost all these is just an echelon 10 microcatheter. Occasionally, if the branches are particularly small or tortuous, we'll switch out to a dual microcatheter. And then in rare cases, there are applications where a scepter is useful. Again, this requires a 6 French guide cath. But if you say you have a proximal artery that you don't want to embolize into, so a meningo-ophthalmic artery or something like that, you sometimes can put a scepter into the blood vessel and inflate that to block off any kind of reflux into an unwanted anastomosis. But typically that's not necessary. Almost all these cases can be done from an echelon. And so the way that we do these cases is navigate into the easiest, straightest branch as far distally as possible. And usually this is the posterior branch of the middle meningeal artery. And so rather than embolizing like you guys do from particles using a proximal branch or staying just at the level of the foramen spinosum or just slightly further than that, we're actually navigating out quite a bit more distally with our microcatheter. And so if this is just a standard angiogram, what we're doing is navigating out this posterior branch, which is typically, again, the straightest, easiest access branch. Getting an echelon 10 microcatheter out here is trivial. It just takes, maybe a minute to navigate out here. And we're going to embolize from a distal position to get these branches. And then we're going to reflux through the meningeal membranes and then backwards into these other branches in the middle meningeal artery in most cases. So a lot of times just from a single catheter position, you can embolize the entire meningeal territory, and I'll show a few examples of that. So the first thing we do, we navigate out, we'll do a super selective angiogram to get a picture. So get a microcatheter in a wedge position. And you can see when you do the injection, you not only see the distribution of that blood vessel, but you easily reflux through the membranes into these proximal vessels and into these other contributing anastomoses of the middle meningeal artery to the meningeal membranes. And so you're actually penetrating distal into the membranes to the extent that you're refluxing back into these other meningeal branches. And so this is something that you cannot obtain with particles in terms of this level of penetration into the dura. For most patients, we'll inject a little bit of verapamil to dilate up the artery to the extent possible prior to initiating the embolization. So after our micro run, we'll super selectively inject verapamil. If the patients are awake, or even sometimes if they're asleep, we'll inject a little bit of lidocaine. So about a half a cc of the 2% cardiac preservative-free lidocaine. And what that does is it anesthetizes the branch and anesthetizes the membranes to the extent to where in an awake patient, you can do these embolizations with the EVOH without actually stimulating too much in terms of pain response from them. In the asleep patients, you'll note that it blunts any increase in blood pressure or heart rate that you sometimes see with the DMSO injection. Then we inject DMSO for the dead space, and then we commence our injection. So our liquid embolic injection, we start out pretty quickly, and oftentimes, again, from just one catheter position and one injection, you can cast all of the meningeal arteries that go to the branch. Sometimes you don't get the anterior branch, and so we'll repeat a second catheterization of the anterior branch and do that. We do a dyna-CT after all the cases are controlled to see the distribution of onyx and to exclude any type of complications. So again, we think the liquid embolic is superior because the distal penetration that it gives us is what we're looking for. So we're trying to devascularize these small blood vessels that are causing the bleeding. Getting a proximal embolization sometimes will not do that because there is communication from the left side to the right side to the left side. So if you get a proximal occlusion in a lot of patients, this won't be effective in terms of resolving quickly and repeatedly, reproducibly, reliably their subdural hematoma. And also, this is a very fast procedure. Although there is some increase in size of the middle meningeal arteries in some of these patients who have chronic subdurals, we're talking about old patients with diseased vessels. These are not like vessels that feed a meningioma or a dural fistula where they're markedly hypertrophied. These are still really, really small vessels. And so PVA particles are irregularly shaped, and you inject them and they form clumps. And so while you may see contrast passing distally, there's no guarantee that your particles are passing distally. And so what I would argue is a lot of these suspected distal occlusions that we're getting with particles are actually fairly proximal, I think, as these particles clump up. Because in these small vessels, even with a smaller microcatheter or 21 catheter, you really don't have great brisk antegrade flow in these small vessels that are going to carry your particles very far. With the liquid embolic agent, we can actually control exactly how far this agent is going and infusing into the dura. So there's a few types of settings that we do this. We do this as a preoperative embolization. Sometimes we do postoperative embolization for patients who are going to surgery, and as sole therapy for patients who are not good candidates for surgery. And so this is a preoperative embolization. So you can see this patient's got large bilateral subdural hematomas. The plan was to take this patient to the OR for evacuation of this. Nowadays, we would probably just do embolization for a case like this. And so you can see this patient's got large bilateral acute on chronic subdural hematomas, and the arteries may be a little bit bigger than in a patient with the standard middle meningeal artery, but it's still not very big arteries. These are little teeny tiny arteries and little teeny tiny branches. So you can imagine injecting particles, from the foramen spinosum or from a proximal catheter position. You're really just not going to get a great penetration distally, even if you use really small particles. So we want to get these two branches. Catheterizing the posterior branch is very, very straight, very, very easy. Do an injection, and again, you see the distribution of that artery and reflux back into the outer arteries. So this catheterization takes maybe 5 minutes to do from the point of doing your diagnostic angiogram to getting your microcatheter in place. And then when you inject the onyx, it looks like this. And so we can do a onyx injection. And so this is just a real-time onyx injection. And so you can see you're immediately casting in a very controlled manner the distribution that you wanted to get. And then you're infusing through the membrane. So you're casting the membranes and then casting back all the way into the anterior branch. So you're getting a very thorough embolization of the entire hemispheric middle meningeal branches in a matter of 10, 15 seconds. And then you pull the catheter out and you can do the contralateral side. So the patient's contralateral side looks like this. There's this one dominant branch that we're going to catheterize. So again, getting a microcatheter into this position for somebody who has good catheter skills like you guys do a lot of other cases. This is actually a trivial case to do, so easy to navigate. You can see from the injection, we're not only seeing the distal membranes, but all these proximal membranes, and you can see the caliber and size of these vessels. So you can imagine even small PVA particles clumping together are not going to penetrate into these distal vessels. And so once we get that catheter position again, we can do our injection. And what you can see is from a single catheter position, you're not only getting very quickly that distribution that you wanted to get, but you're getting all the membranes and then through these membranes, you're refluxing back into the other dominant meningeal arteries in a very controlled fashion. And so you can see exactly where your embolizate is going. You know that those branches are occluded, and you can control exactly what you're doing. And these cases literally just take a few minutes to do. And so again, we pull out the catheter and have a full embolization. So the embolizate is visible. So PVA, we know where the contrast is going, but we don't really know where the PVA is going. We only see the flow stop in these branches. We're assuming the PVA is penetrated distally, but we really don't know that. Liquid embolic, though, is really well visualized. And so especially in terms of doing a trial, we can actually quantify how much we've injected, and we know exactly where that's gone by the distribution that we can see on cone beam CT. So you can see on cone beam CT after this case, you can see the distribution of onyx very vividly on both sides throughout the middle meningeal arteries. The patient ended up going to surgery again as planned for evacuation. And you can see in the middle meningeal membranes all of this distribution of onyx on the post-surgical CT scan within the actual membranes. So the other thing about the liquid embolic agents is they're permanent. So our idea is this is a chronic pathology that is something that has a tendency to recur, as we discussed previously. We want to embolize these patients with a permanent embolic agent that's going to prevent any kind of recurrence. So PVA is resorbed and mecanized, but our liquid embolic agents with onyx are recurrent, and we have not seen recurrent hemorrhages on the same side of a patient who's been embolized here. This is a second case. This is a guy who was on Eliquis who fell, and he hit his head and he got a subdural. And so another thing that's not appreciated in a lot of these surgical series are the complications that occur not from operating on subdurals, but just by treating these patients medically. So this patient was on Eliquis, and it was discontinued during his hospitalization because he experienced a subdural after a fall with Eliquis and had a mixed density acute on chronic subdural. So they stopped his Eliquis, and on day 4, he experienced left-sided weakness and hemianopsia. And so you can see he's got this acute and chronic left subdural hemorrhage, but also on a CTA, he's now occluded his right PCA because they stopped his Eliquis while he was in atrial fibrillation. And so we can go up through the radial artery and just put a benchmark catheter up there. You can see there's an occlusion of the right PCA, and so we can revascularize that very quickly. And then we can just go up the contralateral side, the side where he's got the subdural hematoma with a Simmons glide catheter just through, again, our 6 French sheath, do our super selective external carotid angiogram, catheterize the posterior branch. Again, very easy to catheterize these with the echelon catheter. It's a very straightforward, easy catheterization. We're just going to take this out into the large posterior branch where it goes most easily and just get as distal as possible. So that literally just takes a minute to do. We shoot our super selective angiogram. We see the blush of the membranes and the reflux into the proximal meningeal arteries. And then once we're there, we can do our injection of onyx. And again, this just takes a minute to cast not only that distribution, but to also start back casting the other portions of the vessel. You can see a lot of times you'll get these little anastomotic channels that go through the skull and start anastomosing with scalp branches. And so we stop our injection, give it a minute, then we can just continue to inject into that same distribution. Sometimes you'll see these diploic veins that show up, and then we'll pull our catheter back to do a controlled pullback and embolize some of the more proximal branches. We can then catheterize the anterior branch. Again, this just takes a minute to do. Very straightforward, easy catheterization of these branches. Get our microcatheter out into a good distal position, do our super selective injection, and then again, embolization of the anterior branch. You get a good distribution of embolization throughout the anterior and posterior branches here. And so this was what the subdural looked like preoperatively. 3 days after the embolization, you can see when we do these liquid embolic cases, we note that these subdurals absorb actually very quickly. And so quick resorption of the subdural, and he's immediately able to restart his Eliquis right after the procedure. And so for our patients, again, if they present with subdural hematomas, we're not discontinuing their anticoagulation, we're not discontinuing their antiplatelet medications. We have enough confidence now with these liquid embolizations that we feel we're really able to get hold of the situation with the chronic subdurals. And so we maintain all of the anticoagulation from the time of admission through the time of embolization. Now that we've gotten more confident with the procedure and seen the results in our patients, our neurosurgeons are happy to discharge these patients very quickly after they're embolized. This is just a third virtual case. So you can see again the standard distribution of the meningeal vessels in this patient who's anticoagulated. We get our microcatheter out distally and do the injection. And then the onyx injection again looks very similar to the other onyx injections that I've shown you. Just a very quick procedure, just taking a matter of seconds to do the injection, and getting a very thorough embolization where you can actually visualize penetration of the membranes and then reflux back into the other branches of the middle meningeal artery. And so you can get a very, very thorough casting of these distal branches and then do a controlled pullback to get some of the other branches. You then catheterize the anterior branch and go in and do an onyx injection there. And again, you can do a fairly quick onyx injection. You can control your reflux as the anterior ethmoidal branch, which you know can potentially communicate with the ophthalmic artery. And so we'll watch that on the A plane, make sure we're not embolizing too much into that, but we can control and see. So if you were to get into something like a meningolacrimal branch or something that potentially could communicate with the ophthalmic, you can stop well before you're going to get towards the ophthalmic artery or retinal artery. And so our case results have been just so good with this type of embolization, with just, we expect complete resolution of these subdurals in almost all cases over the course, usually of about 1 to 3 months with resolution. So you can see how quick this happens. This is November 12th. The patient's embolized on that date. On November 20th, it's almost going away. And on December 17th, about 1 month later, these loculated subdurals with all this mass effect using the liquid embolic technique are essentially gone just about 1 month after the procedure. Again, this June 15th to January 15th, complete resolution in this patient. Very large, complex subdural. Most places you'd see this patient undergo surgical treatment of this. We're now treating almost all of these patients non-surgically unless they're presenting with severe focal neurological deficits, if they have any difficulty with surgery that could be age or anticoagulation or something. So with embolization, we just have such a good reproducible cure of these patients that almost all these patients who were going for surgery before were embolizing and just getting very good reproducible results with complete resolution of the hematoma in most all cases. And you can see how large these collections are that our surgeons are now avidly referring to us for sole therapy for embolization. And once you start doing these cases and you relieve your surgeons of having to deal with these types of patients, the more you start doing this, as you guys I'm sure have seen in your own practice, the more referrals you'll get for these cases, because as soon as you do 1 or 2 of these and the surgeons start seeing the results without surgery, they're very happy to sort of give you these cases to embolize. So these are just a few more examples. You can show millions of them. So this is, again, just another example of how big these collections can be and how avid our own surgeons here are with referring these patients for embolization. So this is just a few months follow-up in this patient who had almost a 4 centimeter subdural, was on anticoagulation for a heart valve. And so just through embolization, we're able to get rid of his symptoms and resolve the collections almost completely. So we've treated 40 patients already who are just sole therapy. So these are patients who are not preoperative or postoperative like we started, or patients who have multiple recurrences after surgery. That's what we started with. We started to go towards this as like a sole therapy type of treatment. So we've got 2 patients who were too early for follow-up. We've got 4 that were lost to follow-up. Of the 27 who have follow-up of at least 3 months, we have only 3 that have not resorbed their hematoma to less than 1 centimeter. And we counted as 1 failure a patient who had a contralateral subdural to the side that was embolized. So we embolized one side for a chronic subdural, and then a few months later, he showed up with a contralateral subdural. So we counted that as a failure too. So the success rate is extraordinarily high for this procedure, around 90%. Counting, again, one patient, that patient that I showed with the very large subdural, we counted this person as a failure because for success, we say the subdural has to be less than 10 millimeters. But again, if you start at almost 4 centimeters, less than 10 millimeters, a pretty difficult endpoint at 3 months. So the success rate has been very high. And so why we prefer this is because this is a very, very fast and reproducible technique. And so you get out into the artery, and rather than puffing PVA particles into a small artery over a long period of time, you're just getting a wedge position with the catheter, embolizing the entire hemisphere, oftentimes from a single catheter position. And again, these cases can oftentimes just take a few minutes to complete. These are technically easy cases. So the approach versus the normal procedures we're doing with complex aneurysm embolization, AVM embolizations, this is an easy, fast, simple procedure to do. And it's safe. So far, in the 40 sole therapy cases that we've done since 6/18, we have not had any complications in these patients. Again, I think because we're so far away from these dangerous anastomoses, we have our catheter very, very far distally. We can see exactly where our embolisate is going. And so we can stop before we get into anything that looks like a dangerous anastomosis. And we're far distal to most of the dangerous anastomoses, which are at the skull base. And in this small population, it's been a very effective technique. And so we really look forward to the STEM trial, and we look forward to proving that this is a useful technique, because I think it's, again, like thrombectomy, one of these very rare times that we have such an opportunity to change the way medicine is practiced. So thanks for your attention, and I think we can open things up for questions at this point.